Hello, everyone. My name is Giovanni Nogales, and I'm a paralegal here at Liles Parker. Thank you for joining us for this new webinar series with the Home Care Association of Louisiana. Today's webinar is entitled Risks Facing Home Health and Hospice Agencies on Hiring Individuals on the OIG Exclusion List or the CMS Preclusion List. This is just a quick reminder. If you have any questions throughout the presentation, please feel free to type them in the chat box, and we will address as many as possible at the end of the presentation. So without further ado, I present your speakers, Robert Liles and Paul Weidenfeld.
Thank you so much, Gio. Well, it's a beautiful day here in D.C. for once.
The weather's great.
The weather is great. We are so tired of winter. You know, you're sitting here talking to a country lawyer from Texas, and Paul, as you know, was a federal prosecutor in New Orleans. We're here today to talk about exclusion and preclusion issues. And I'm really thrilled to have Paul with me because Paul is, in my opinion, the foremost expert in the country on exclusions.
Well, thank you, Robert. Always a pleasure to be here. And you are the foremost expert in just about everything else when it comes to healthcare, as far as I'm concerned.
Not according to my wife.
Well, okay, healthcare.
There you go. There you go. All right. So, Paul, what are we going to talk about today? We're going to talk about exclusions, correct?
So we're going to talk about exclusions and the effects of exclusions. And, you know, so it's not as if folk in home health and hospice don't realize that there are enough risk areas, right?
Right.
I mean, CMS, DOJ, and OIG, everybody's after them for one thing or another. The hyper focus because they take care of people. I think that's the reason why there's this hyper focus. I'm just not really sure.
Well, and for our friends in Louisiana, right now, their counterparts in Texas are pretty much getting it on the chin. The hospice folks are subject to PPEO, just as California and Nevada and Arizona. And on the home health side,
and Georgia, right?
Yeah. And on the home health side, it's almost as hairy. It's pretty bad, really, really bad for hospices. The reason I bring this up though is because what are they doing to them? They're revoking them. Okay, and why are they revoking them? Well, one of the main reasons, well, not a main reason, but one of the reasons that they use as a basis for revocation, which essentially takes out your Medicare billing privileges for up to 10 years, is because of an exclusion matter.
So, and that's the point here. There's easy to focus on everything else, but I think as you've said at times, exclusion is like the one issue that's big but tends to get overlooked.
No question about it. I think it's the most significant risk issue facing home health and hospice today that no one seems to really take into account.
So let's talk about it. And that's the reason for this first slide. So, all right, we think of it as a new issue, but Robert, it's been around for a long time.
Oh my gosh, unbelievable, unbelievable. Exclusions have been around since 1977. I was still in high school, and here I am fixing to retire. So it's been around a long time, Paul.
That's almost half a century, right? And that's
yes.
49 years now.
That's right. That's right.
It's 50th birthday. So
and I will tell you, Paul, just this week I was talking to Ashley Morgan. Many of you on the phone know Ashley. I was talking to Ashley Morgan, and we get inquiries all the time on our website from people that need help. She said the number one reason over the last week that we've been contacted was because of someone with an exclusion problem.
That's interesting. And the thing is, when they passed this in 1977 and have been keeping it up for almost 50 years now, it's because, and I'm not sure that this is a true belief, but this is the belief is that by keeping people out, it really does protect the system and it does protect people.
Yep.
And whether they exaggerate the percentage or not, the fact of the matter is, it does keep, having excluded people out of your process. There's a lot of good reasons for it, and we're going to talk about it. And there's a lot of penalties and a lot of bad things that happen if you have excluded people. So it's really.
But why are home health and hospice so subject or so likely to have this problem? Why is that?
And well, there are two reasons that exclusions are there: to protect programs, financial, and to protect patients. And home health and hospice really go right to both issues. They deal, there's a lot of money involved, programs that they think there's fraud, and they're touching people all the time. They are directly connected to beneficiaries. And so those are the two reasons that exclusions exist in the first place, and they really implicate or touch both of those reasons.
And what about the fact that they're comprised primarily of nurses?
And the other thing is, yes, as we'll see in a slide or two, a high percentage of excluded people are nurses or are direct care workers, and so that we'll see that, we'll discuss that. But yes, nurses, direct care workers are the people who are most likely to be excluded, not physicians, as we see, and we'll talk about that in another slide. But that's another reason.
Yep.
So,
okay. So what is an exclusion, Paul? I mean, at its core, what is it?
An administrative action taken by the Office of Inspector General.
Can any other agencies take an exclusion action?
Nobody else can take a federal exclusion action.
At least the Medicare exclusion action.
Right. States,
okay.
and any other action by another agency is maybe a debarment, but they're the only ones that actually exclude and say you can't be in this business.
States can, though, for Medicaid.
States have their own, and some people call them exclusion. It's funny. And the regulations that come Medicaid exclusions, CMS calls them terminations. It's kind of the same thing. Some places call them, they call them different things. But yes, states can bar someone from their own state. Then, and we're going to talk about this later too, states can that action can become the predicate for a federal exclusion or a termination exclusion by another state.
Gotcha.
So they are administrative actions. Once they're imposed, that's it. It's not like, an arrest or something, or even there's some kind of convictions where you can't work at somebody, but then you can, and it depends on it. An exclusion, it doesn't matter the basis of the exclusion, the effect is going to be the same.
Interesting. Next. All right, so if someone convicted of a crime and they're excluded, that exclusion is treated the same as someone who is just excluded because they've lost their license for a month because they didn't pay their dues.
That's right. And so there are two types of exclusions. What you just mentioned them, only didn't call them by their name: mandatory exclusion, permissive exclusion. Regardless, if you're excluded, it's going to have the same impact. Mandatory exclusions are based on convictions. Some say some are felonies, some are not, but it's a conviction typically, and we're going to talk about either for healthcare fraud, patient abuse, or certain drug offenses. Permissive exclusions are, and there's a whole laundry list of them, but at the end of the day, most of them involve the same conduct: fraud, patient abuse, or drug offenses. The primary basis for permissive exclusion, we'll talk about in a minute, is licensing issues. But let's go to the next slide. Robert, these are the 4 mandatory exclusions, right?
Yep.
Just only 4 of them.
But they're quite broad.
Extremely broad. And you'll notice that the first 2, one is a conviction of a criminal offense related to the delivery of an item of service of Medicare or a state healthcare program, and the other is a conviction related to neglect or abuse of a patient. The others are felony convictions. Now, the percentages are below, almost 60% are based on the top. Now, a conviction, Robert, as we have discussed many times,
it's not really a conviction. It's much broader.
It's really not, is it?
No, it's like knowingly under the False Claims Act. It's quite broad.
It's pretty shocking. So a conviction can be a no-low plea is a conviction.
Yep.
Under the statute. A deferred prosecution is a conviction under the statute.
And this is kind of a problem, isn't it, Paul? Because folks they're charged with healthcare fraud, for instance. They'll go out and they will hire a really good criminal defense attorney. And that really good criminal defense attorney may be able to cut a great deal, such as a deferred prosecution, which essentially is, if you keep your nose clean for this long, it didn't happen.
Yep.
Right? But
I've written an article on this.
The problem is that these guys, they're great, not taking anything away from them, but they don't understand the collateral consequences of these pleas.
they may be the best deal that they could get,
Yep.
but many people have been surprised. So, for instance, and here's the other trick: it's related to the delivery of an item.
So it's not even your charge. It's if healthcare is anywhere in the picture.
That's exactly right. So we have both seen cases of a misdemeanor conviction for, say, misuse of a computer, right?
Yep.
Well,
Yep. How
I
could that possibly result in an exclusion?
well, except that what actually happened involved you use that computer to make a false claim or whatever.
Federal program.
Oh, and that makes it related to. So if it touches it in any way, it's incredibly broad. And so either one of those. So if you've had somebody who, and here's the other thing, a lot of times people don't know they've been excluded, and we've both come across this because frankly, when you've been, you're charged with something, exclusion is going to be based on a conviction probably. But once you're in that you're just crazy about that world. I've done criminal work. I understand that. Well, they may not they got another piece of paper from the Office of Inspector General. They may not even be getting their mail, right?
Yeah.
Their lawyers bailed on them. It's over. They think. They may not know about it. Well, I didn't plead guilty to anything. Oh, that was expunged, they'll say.
Yeah. Well, the other problem with it is, and we've seen this repeatedly, situations where the nurse or the doctor never lost their license. Even though they took a plea for healthcare fraud, the board, after learning about the facts, said, yeah, okay, that's really bad, but we're not going to touch your license.
Or maybe it wasn't so bad.
Or maybe it wasn't so bad.
Maybe it wasn't.
Maybe it was a misdemeanor for misuse of a computer.
It truly was.
And they don't take away a license typically for that.
Or maybe, and this often happens, that someone got caught up in a scheme. So the real bad guy, they pled guilty to a felony. They go to jail. You're there, and the lawyer says, well, we can take this plea. It's going to be expunged. I've already talked to the board. You're going to keep your license. Everything's cool. Yep. And they say,
right.
oh, well,
let's do it.
Let's do it.
Yep.
And then you find out. So, and these are the permissive exclusions. So
well, there's a lot.
There are, and this is not all of them.
Now, the one that's in red, why is that in red?
Because that's the big bopper. That's the one, any kind of license revocation, suspension, surrender. A lot of, what used to happen is all the time is that a physician or a nurse, they'd get in problem with their licensing board and they'd surrender it in lieu, and so they wouldn't have any, and that would end it. Well, now the surrender of a license is considered to have the same effect as having lost that license. And so the thing is, so 90%, I think we'll see there's a slide on the percentages, but the vast majority of permissive exclusions are on that basis. And Robert, we know why it's on that basis, don't we? Why?
Why is on the licensure?
Why are we doing it on something that can't be questioned? Because, right? They can't question the underlying basis of that.
That's pretty much, well, that's not the case in all of the permissive exclusion bases. It is the case in all the mandatory exclusion bases. And that is that, once it happens, it's happened.
And
there's no collateral attack to it.
And licensing has that same effect. You can't collaterally attack the basis of the license.
Now, just I know we have way too many slides, but quick question. Yeah. Of the license basis that we've got here, whether it's revocation, suspension, that kind of thing, how many of those, what percentage will you say are people that just didn't pay their dues, like an administrative suspension? I think because I've seen it happen.
We have both. I have seen, and this is really one of the horrible things about licensing disciplines. Number one is you can be disciplined for a lot of things, and a lot of times people, and it was not uncommon to just say, all right, I'll pay the $500 and I'll accept the suspension. It's deferred, and if I go to this program, but that counts as a disciplinary action, and we have seen.
Wow, that's the licensure version of the word conviction, huh?
The licensing version of a misdemeanor for the computer fraud. That's right.
Wow.
and that can be the basis, and you can't question that on appeal. So what happens is, if you look at the top, so that's 90% of all, and then misdemeanor, those convictions, those top 4, between them, they constitute like 97% of all the convictions, because the OIG doesn't have to fight that. You can't fight the OIG on them. You can't appeal them. Now, the only other interesting one that we always find is the failure to pay loans.
Oh, yes. And we have seen those cases. For many, many years, we didn't. But in the last few years, we've started to see cases where people defaulted on a loan.
But then they stop.
Then they stop for a while, then they pick it back up again.
So anyway.
I don't know if that's administrative whatever, but whatever.
So all of these other things, the failure to take corrective action, immediate access, those are things that can get you revoked.
Yep.
Those are things that can get you suspended, but they're not going to get you excluded.
Gotcha.
Let's try the next slide. And here's my, as you can see, these are over the last 5 years, or the total. So 5% constitute loan defaults, which is interesting. And that's the total.
Higher than I thought.
But
now that one up top comes up a lot these days, owned by excluded party. On the revocation side, even if they're not excluded, but if they were revoked, now we're starting to see them. This is important, folks, in Louisiana, because, we're seeing this in Texas now and California. If you have an entity that is revoked, CMS is now looking to see what other companies you have an ownership interest in, and if it's more than 5%, now they're starting to go after those companies to revoke them too under the affiliation rule.
Absolutely. And so it's interesting that the ownership by excluded party, you have to divulge all of the people that on your enrollment and stuff.
Now, we've seen a couple of criminal cases on this where an excluded party would hire like a dupe doc, some poor doc that's down and out or 80 years old or whatever, and then they would continue working, and then they would bill everything under that doc's number.
This is a huge, huge issue, because what they finally realized is that excluded people try to get back in the system. And so but they know they can't do it directly. So what they'll do is they'll provide a service and then have somebody else bill it under their number.
Scary.
Or what you'll find here is that they will, they may be an ordering physician. Because remember, they can have their license.
Yep.
And people need to be very much aware of the fact when you take referrals, that doctor can have their license. It can be a legal referral.
The doc's licensed. He can see a Medicare patient. He can treat a Medicare patient. He can't bill Medicare.
That's right.
And the problem is he can issue a prescription that is a good prescription, but a pharmacy can't fill it.
And
they can fill it, but only cash pay. You can't fill it and have Medicare pay it.
Similarly,
and all these folks have that problem because they all have referring docs.
Exactly.
That's the problem, because if those docs, even though they're licensed, even though they can make a proper referral, if they refer a patient to your home health or hospice for Medicare or Medicaid, okay, and then they're excluded, and you turn around and bill for those services, now everything that they've given you is tainted.
Exactly. They can be legally a medical director. They've got a license, right?
Yeah, but the problem with that, though, is the medical director many times is asked to certify or to review or to sign off on. All of that is a problem.
That's exactly right. So in other words, they may come, and the nurse and home health needs to be really aware of this. The doctor can make the referrals, right?
And also, wouldn't that also qualify as, if someone is excluded, or everybody on this phone call, you cannot hire someone who's excluded. You cannot have them work for you as a agent or a contractor. I would think that a medical director would fall within one of those categories.
Absolutely. And how about someone that's working and just making referrals to you? You see,
it's poison.
It's all poison, and so you need to be aware of that. In fact, we've seen cases where, and this is where DOJ and OIG have shifted a focus, and they're looking for people who have been excluded trying to get back in through the back door. Because as we're going to see, the exclusion is direct or indirect. All right, and here it is.
Yeah. And we've been talking now about indirect, right? Direct would be, everybody on this call today needs to be screening all your employees, agents, and contractors every 30 days. We're going to be talking about that.
We're going to
right?
talk about that at length.
But also, you need to be screening every doc that sends you a referral.
That is, I think for this audience, for this group, home health and hospice, who are always getting referrals from various sources. I mean, you have to get a referral to get there, right? And they may or may not have their own practice. They might have, say, they can have a practice if they've got a license. It happens, and and it may be a cash and carry practice. So you don't know what kind of their payer mix is, and you may have no reason to question it. But if they're making referrals to you and they are excluded, you can't take that excluded.
Okay, let's next one.
So an indirect one is the one that they're worried about. So this is an indirect one would be, I'm excluded, I provide a service, you bill, but let's bill it under your number.
Right.
Can't do that.
Can't do that. And I will tell you that the cases we've seen where an excluded party tried to use the system by billing something under everybody else's number, those cases have uniformly gone criminal.
And in fact, it is a criminal offense in Louisiana for an excluded party to make a claim. It came under a biller. A doctor got excluded. He became a medical biller, and he started billing Medicaid. He said, well, Medicare, Medicaid. He says, well,
you gotta make a living.
I got to make a living. I know the system. I'll do it. The Louisiana Supreme Court said, no, that qualifies as providing services. So, and it extends to virtually everybody who you have to screen, and we'll talk how often and stuff, but the payment prohibition, it goes to anybody, administrators, billers, surgical support, HR, IT. The one that is the most shocking is the fact that an excluded volunteer you didn't even have to screen them if they are helping you provide part of your bundles of services. The best explanation of that is in a nursing home context where, they're getting paid on a per diem, and a volunteer comes. He's been excluded, but he just wants to help around, and he figures that's okay. It's not. Oh, it's not.
Yeah, all right, but for our context here with home health and hospice,
right? If
there are folks that are going through school, they want to do an internship, whether they're a social worker or whatever it is.
Good point.
You gotta screen them. The other problem is, big problem is many of you use the services of a staffing agency.
You're right. Staffing agencies are a huge problem because you assume that they've screened them, but they may or may not have done that.
And we've seen cases where that didn't happen, and there was one doctor they had sent to 5 places, and he tainted the work in 5 different locations.
And they may screen the federal list, but they may not screen the state list, and they could be excluded by your state. So you get through. If it's somebody that's in your facility, and they're providing a direct service. Now, what about?
Okay, let's go to the next slide. We're going to run out of time pretty soon here.
So, what about one question? What about waste management? Do you have to screen them?
I think you ought to screen, yes, because they come into the facility. I think that's not really a rule, but my kind of impersonal rule is if they're coming into the facility to empty out those red boxes,
absolutely,
they need to be screened.
If they're just doing the dumpster?
No.
I agree. So any payment made in violation is an overpayment. Anything made.
The other thing I'll say though is, if it impacts the overall basket of services. Okay, and since waste management falls under OSHA, and OSHA is definitely something that is important in the basket of services, I think that would definitely be something that you'd have to screen. Yeah,
that's an interesting question. I haven't really gotten to, I agree on the inside. If they're the company, it makes sense. There's simple rule is if they're affecting your services and paying it, it's easy to do.
Okay.
So. They're overpayments.
So that's a good question. So let's say that we've got a home health agency, and we hire a nurse, and it turns out that nurse, the day that we hire them, they're okay, but then they didn't tell us that they had gotten in some trouble, and a week later they're put on the exclusion list, and we don't know it.
Right.
So what does that mean?
So you're responsible for the overpayment, And then hopefully you've screened them the next month and then taken care of it. And we'll talk about how to deal with that. But, the thing is, what is an overpayment for? An overpayment for a doc is easy.
Yes,
we know what they bill.
It's what they bill.
Right.
But for a nurse, it's kind of hard.
It's hard. Now, if you self-disclose, we'll talk about that again at the end, but let's just hit it real quick.
Yeah.
If you self-disclose, there is a reasonable format or a proxy for dealing with that overpayment.
So they figured out a formula, haven't they?
That's
To say, well, for a non-biller, maybe a nurse, maybe a receptionist, maybe whoever.
That's right.
In a doctor's office, but for a non-biller, they've got a formula that will help you come up with a fake overpayment that you can pay back.
And basically it looks at how much you've given that person over time and your payer mix, and it's relatively simple.
Yeah.
If you don't have, however, if you have not done it by self-disclosure, there's really no fixed way. Every claim is theoretically tainted, and you are basically at the mercy of the Office of Inspector General.
That's if they find it.
If they find it, that's
right.
And payments, and just quickly, a payment has to be reported and repaid, investigated, reported, repaid. If not, as you like to say, like water to wine.
Yeah, like Jesus turning water into wine, it turns into a false claim.
The OIG turns it into a false claim, which then can be subject to a False Claims Act case. So there's, in addition to the overpayments, there's also incredibly high civil money penalties, which is just the hammer that you just got to take care of it.
So OIG, let me get this straight. OIG doesn't even have to send it to DOJ for pursuit under the False Claims Act.
No.
They have their own administrative penalties that they can assess.
And look at the size. It's per claim.
So it's like this. It's like the False Claims Act in that it's per claim plus damages.
Right. And so you get so in other words, it's so much money that it basically, again, now we're going to talk about screening in just a minute. By screening, you avoid the civil money penalties. That's the heart of screening. They will not. They say they will not impose civil money penalty if you screen appropriately upon hire monthly thereafter.
Okay.
However, look at it's so much that once again, if you're in violation of it, you're at their mercy.
Now, have we ever seen the very bottom one there? Those numbers are really high. Have you ever seen any? I've never seen any Medicare contracting organization assessed a penny. And Medicare Advantage and Part D, they're screwing up all the time, but I don't think I've ever seen OIG hit them either.
I have never seen such a case either, and I'm always looking for them. It's very, very interesting.
So they only go after people that can't afford it.
More or less.
Yeah.
It is rather shocking that the contractors are not held to the same.
Yeah, because Lord knows all the reports coming out, it's not like the contractors have done everything else correctly.
Yeah, right. Right. I'm not even. We're not going there.
Okay,
Robert.
next slide. Yeah. Okay.
So here's the other thing. Other than check the box, and other than the fact that you're obligated, and other than the fact that these people are, that you face these overpayments and you face civil money penalties, let's just think about taking it down to its core. These are people who have been adjudicated to have a problem. Now, you may or may not agree, but the fact is the OIG says that they are a risk to the program and your patient.
It really is important when you think about it. The reason why they're excluded is not something that can be taken lightly. And would you really want them taking care of your parents?
And it's exactly right. And look at every single risk that you really face, your legal risk, your patient risk, your human capital risk, they all come down to people.
Yes. And they're saying essentially these are bad actors. We don't want them having anything to do with our beneficiaries, directly or indirectly.
And as a matter of law, you can't really question the OIG's determination.
No.
You may disagree with it, and frankly, you and I have seen cases where we said that's BS. They never should have excluded this person.
Because it's not. There really is no equity among the system. One doc will get away with
Right.
no action, and another doc will be kicked out for 20 years.
But the fact of the matter is, you can't, since you're not allowed to question it, and it's not your place to question it, not in the context of the risks that you face and the risks to your to your business and the risk to your patients and the risk to the government.
Right.
So, people really are what it's all about.
People are the risk. That's the risk. No question about it. That's the headache.
So, states, we talked about that briefly. States can terminate or exclude. They call them different things. Sometimes they say suspension, sometimes they say debarments, whatever it is. Every state can exclude someone from their program. Now, if it's for cause, all right, what does that mean? Typically, it means basis on fraud or neglect, patient neglect. If it's for cause, and there's a little diagram, that's a CMS diagram. What they're supposed to do is when they...
That diagram?
Huh?
Did you do that diagram?
No, not that.
I was going to say, that's pretty fancy.
It is a good one. I liked it. CMS did that one.
Okay.
I stole it from them. And they said, this is how you're supposed to do it. You take it, you're supposed to publish this to your sister states and to the OIG, and they're supposed to determine whether or not that fits their basis for exclusion. Now, the interesting thing about that is that, by definition, you're going to have a big gap between the state exclusion and if the state exclusion comes first or termination, there's going to be a big gap between that and the OIG exclusion, right? So if you're waiting and not doing the state, you can be missing something, and we're going to see an example of that.
Let me just say this before you move off of states for a second. For the folks on the phone in Louisiana, it's not enough, in my opinion, for you to only look at the LEIE, which is the OIG's list. And does Louisiana have its own list? It does, doesn't it? Yeah. It's not enough to just look at those two. You could have someone who is excluded in Texas just next door, and they just drive across, but they've got a license in Louisiana as well, and they just drive across the border, and you're going to miss that person. You have to do a screen of all states.
And so we will talk about that, and it does in fact happen that people do. We'll see we'll see an example of that. Okay.
Yep. Next.
OIG guidance: screen everybody prior, upon hire or the initiation of contract, and monthly thereafter, for just the reason you said, Robert. It takes, it's not a static thing. I know that from people who have been in the business for a very long time, they can remember when we were only screening once a year.
Right. Yeah, that's right.
We remember it well because we've been in the business a long time. But it's not static. People come and they move, and then the lists change.
I actually had a case in Texas where they were old school. They were only hiring people, or they were checking when they first hire them, and then once a year, right? This guy, he was clean when he was first hired, and a week after he got there, he was put on the exclusion list.
That's right. We've had at exclusion screening, we have a number of cases like that. In fact, most of the excluded people that we have found as part of exclusion screening have been people who were okay when they came on board and got excluded later. And we've had owners say, "Oh, I was wondering if that was going to end up being an exclusion." That was one of the crazy things.
And of course, the people will not tell you because they know that they cannot be employed. So it's not at all uncommon. Sometimes they know. Sometimes I actually believe them when they say, "I did not know."
Well, I absolutely do believe a number, not always, but for instance, people who've given up their license and then they say, it used to be very common to surrender your license and then move on. They may not even realize that they got excluded. They're not at that address anymore, and on and on. So it does happen.
Next slide.
So there are different, and this is interesting, so that the OIG doesn't have authority to require you to screen anything but the LEIE. If you fail to do that, though, they have the civil money penalty authority to whack.
And that's an important point. There is no law that says you must screen. There's only a law that says if you don't, and you have someone that's excluded, we're going to hit you with a big board.
There's no federal law.
Thank you. No federal law. Thank you.
That's true. state Medicaid programs, every state has and I was in Louisiana. The Mafuco in Louisiana, the fraud control unit was very good when I was there, and these were people that were both professional, competent, smart. They were good guys and gals. So the state programs, they all require, every state requires that you screen at least that state and the LEIE, and most states also require that you screen the GSA SAM. Okay, that's the General Service Administration, those lists. However, as we both know, in Louisiana, it's one of these states, the number of states require in the enrollment.
Yep.
In your enrollment, they say, are any of your employees or vendor contracts excluded from this state or any state or federal healthcare benefit program? Louisiana, in your enrollment documents, requires that you say that you affirm that that's the case. And
Same thing as Texas.
Well, and Robert, in Texas, they have their own special certification, don't they?
They do. They do. As part of the Medicaid participation agreement, you have to swear that you're screening every state, and you have a compliance plan.
And you have to certify that under penalty of perjury.
That's right.
So.
And why did Martha Stewart go to jail? It wasn't because of insider trading. It was because the government alleged that she lied.
Well, we're not going to go there. That's your favorite. That's one of your favorites.
Well, it just shows.
But it is true. Absolutely true. And now here's something else. You must also, your Medicare Advantage and your Medicaid HMOs, right?
Yep.
Your Medicare Advantage plans, Part C's and D, they have their own requirements. Most of them are that you screen your state, the LEIE and the GSA, Medicaid, your managed care plans and your Medicaid managed care, they have requirements. Even private payers.
Well, which makes so much sense to me.
Right.
Because if you're a private payer, if you're Cigna, let's say, or United Health, why in the world would you say it's okay for your patients to be seen by people that the government thinks are too dangerous to see their patients?
Right. That's, or put it cynically, if they ain't going to pay, why should I?
Yeah, there's that point too.
There is that.
Okay, all right. Yeah, that probably makes more sense given the subject, you know.
So where are the lists? There's the LEIE, the list of excluded individuals and entities, the OIG's list, maintained only by the OIG, updated monthly. Removal is not automatic. States have their own list. I think we got 44 states that sometimes goes up or down.
It does go up and down every month.
But they are not uniform in the same way. The Fed, they some can be in PDF.
Some of them are just on a Word document.
We have seen Word
documents.
Some
of them are Excel. Some of them are something where you can't even read it hardly.
Most have gotten to Excel, but not all. But they all have different fields. The CMS Preclusion List we'll talk about later. There are also some other sanction lists. So the GSA SAM, for whatever reason, and this really, I will say this is kind of mind-boggling to me, but it's a debarment list. It's all of the various federal debarment lists, and there were like 20 or something. They all got combined into one. Why that became, you have to screen that for most state Medicaid requirements require. You probably are required to do that. I don't know why, but you are.
Yep.
As well, sometimes those specialties, and you really should check your contracts. Sometimes OFAC is a requirement.
Which is interesting. You know, why do they want me to check and make sure that you don't have any affiliations with terrorist organizations?
You know, we're not going there.
But you're right. That's now a requirement on a number of these contracts.
There is, and actually there are some states that require searching OFAC every 3 years. That's sort of connected to some federal legislation. So you got to be careful. There are other state sanction lists.
Now, one thing I don't see up here is the death registry.
No, you don't.
Because I know that we're getting more questions about that these days too.
That's true. They are concerned. Well, actually, I believe that the plans are required to screen the death registry.
Okay, so all the Part C and Part D plans have to do it.
The plans are doing that because they're concerned about people using the credentials or the Medicaid numbers of a dead relative, or
Okay, okay.
and that's the point of that provider. So, yeah, but
Okay.
you providers don't have that.
No.
You typically take care of living people. Best practice, Robert,
Every month.
pretty simple. Every month.
Wait. Before they walk in the door,
Right.
okay?
Yep.
Then every month thereafter.
Can they,
No, you've had clients who told me that they didn't want it every month. They wanted it like every week or every other week, or.
we have had clients who were very much concerned about that, larger systems or just people with a lot of turnover, as you have in these industries, nursing homes particularly, 100% turnover in that industry, that really wanted it on a weekly basis to ensure that they never had excluded people treating their patients or dealing with them. That's okay. I mean, I think that's good, strong practice.
That's belt suspenders.
It is, and it's not all that expensive. Can you do it on your own? Well,
Theoretically possible.
You can theoretically do the OIG on your own. You can theoretically do the state, but it's really hard.
You'd have to do all 44 states, plus the GSA
You can't do
and
it.
the LAIE. You'd have to have at least 2 FTE assigned to it.
You can't possibly do all 44 states because it's too hard, and they upload at different times. You can possibly do the LAIE. There's 78,000 names on that list, or 85,000 names on that list. You can probably do the state, but Louisiana is a pretty robust list. Like I think it's 8,000 people on it.
Yep.
And if you're doing for like 2 people, maybe, but if you've got 20, 30 people, 15 people, 20, 30 people,
that's impossible.
It's too hard, and there's a good reason for having a vendor. Use Exclusion List. Use anybody else. Check them out.
But check them, because you're going to have a problem if you don't. Next slide.
It's not expensive, and they do well. So this is an interesting slide for 2 reasons. One is you look at the stuff on the right, management position. These are cases. So these, you think,
so these are cases that OIG has brought and assessed penalties because they had an excluded party.
Or agreed upon settlements. These are, and when I saw the housekeeper's information specialist at $180,000, the other ones didn't shock me so much, but it's anybody in there, and physicians only make up about 9% of all of the excluded people, and so this is where they go. The one on the other side, so this health system now. It seems inflated, 18.8, that M is for million. Now, the press release, they didn't release much information about it, but the press release led with the fact that there were excluded people involved with the submission of claims. That's, I'm not saying that all 18 million was based simply on an excluded party, but that's what the press release led with.
Wow.
Personal care provider. This was a Medicaid case. A personal care provider, almost $1 million for having an excluded party submitting, providing services. So, it makes sense as a target, but this is a targeted area.
Yep.
So, reinstatement in the program. Here's something.
Here's the kicker, isn't it? This is the kicker.
This is really important because, it's not automatic. So
that's the point.
You get a 5-year exclusion, a 3-year exclusion, Medicaid permission, whatever it is. It's been 8 years. You come back to that. They come to your office and they say, "I'm a nurse. Here it is. I've got my license. It's good." And you may ask them, "Have you been excluded?" Yeah, but it's over, right?
Yeah, that was 10 years ago, and it was only for 5 years. So
and it was
what's
really,
the problem?
And it was really nothing anyway. I was only a misdemeanor, but. And so you figure, well, it's 10 years ago. It's a 3-year exclusion. That's that.
Yeah.
The thing is, it's a forever thing unless they take you off. It's not like a prison sentence.
What it really is for this period of time, you can't reapply.
That's right. That's a good way to put it, Robert. A prison sentence, get 5 years in jail, okay, after a good time, wherever you're out, it's done, right? this is not done, and they must reapply to get off the list. And they don't really, to get off the list, they make it very difficult. So having an NPI number doesn't mean you're reinstated. Having a license doesn't mean you're reinstated. Being a billing provider doesn't mean you've been reinstated.
Not a bit. That's right.
What we found is that CMS, that they may have billing privileges and be excluded, and then when they reapply, then they get revoked later on.
Yeah, and that's so sad, but that's a different webinar.
That's a different webinar. But the fact is that they're not off it because the time has expired.
That's right.
That's the
right.
point here. So, 2 issues. If you find someone included, can you keep them there because they have a good story?
Yep.
Robert, what would you say?
About the story? Doesn't matter.
Keep them on?
What? No.
No, you gotta get
you can't. They've got to be out of there today. I mean, I'm sorry, but you cannot. If you want to stay in Medicare and Medicaid and other federal health benefit programs, they can't be there.
And so, what do? Can you just sort of say, "Well, we'll get rid of them," or do you? How do you resolve it? Can you just walk away from it? Maybe. Or do you recommend to your clients that they just do a self-disclosure and get it done?
I tell them they need to fix. I don't tell them what to do because these things are so tricky. I tell them you're eligible for rehire once you're off the list.
Okay. And so if your client comes to you and they found somebody, I think you got to tell them.
I'd get them out of there that day, and then I would do a voluntary disclosure, and clean it up before it turns into something worse.
And it's generally, you've done a number of voluntary disclosures.
Yep.
Generally, even for someone that's been there.
I've never had one blow up on us, and knock on wood. I mean, you're telling OIG about something they didn't know about, and you're including normally a nominal check. And these days, in fact, if it's under a certain amount,
$20,000,
it used to be 10, but now it's 20. Then you don't even have to tell OIG. You still have to turn the money in, but you give it directly to the MAC with a nice letter. Okay, so there's ways to deal with this.
So there we go.
But you got to be careful, guys. I mean, the other problem is this is what happens. Let me tell you what happens when you don't screen. We've had a situation where a doc was wanting to get off the list. He was convicted of a case 10 years ago, never lost his license. It was only for 5 years. He's been theoretically eligible to be taken off the list for 5 years, right?
Right.
The first question they ask the doc is, what have you been doing the last 10 years? Okay? Even during the period that he could have gotten off, they still want to know, what have you been doing? And
if they find that he's been doing Medicare stuff, they're not going to let him back on the list.
That's very possible, but they also go after every provider he puts down.
We've seen that too, haven't we?
Yes, we've represented the providers. So, guys, if you're not screening and you pick up a problem, they will find out about it. Even if the guy's been gone for 2 years, he's now putting you down on a list that he worked for you during this time period that he was poisoned or kryptonite.
Strong point. A strong point. So, there it is.
Yep. Next slide. Oh, there are exceptions where someone is excluded, but there's ways where they can possibly be permitted to still see Medicare patients and bill for Medicare patients. We've handled 2 of those in 30 years where we've gotten them. One was a carve out where it was a doc that was in a geographic area that there was nobody else to take care of patients. Okay, that's one. Another one, there was no carve out. It was nationwide, but it was because he did work that was so unique and so important that Medicare said, we need him taking care of patients.
And so what are the chances of a provider running into a doc that fits one of those 2?
Well, like I said, I've done 2 in 30 years.
Yeah. And to get the waiver, the carve-out waiver, you have to get permissions from
the head of the Medicaid folks in the state.
And the head of Medicare of that area.
Yes.
I mean, it goes all the way up.
That's right.
So, it's
very difficult to meet one of these exceptions, but I still think it's important to know that there are exceptions.
They are.
But don't unless you have a lot of money and a lot of time, It's not going to happen.
But as they say, the chances are slim to none, and Slim's on the bus back to Amarillo.
That's right. That's right. Okay. All right. The preclusion list. Just when you thought it was safe to go in the water, then we have the preclusion list. And the way it all came up, Paul, is at one point, we all remember when it comes to Medicare Part C and D, those providers would have to go and they would still have to get credentialed by Medicare, right?
Yep.
And at some point, Medicare said, this is bullshit. Why are we doing all this work for you? You're a private company. Do your own credentialing.
Yeah.
So once that broke off and they were responsible for their own, now all of a sudden they realized, CMS realized, but oh gosh, we no longer have any control over who they're letting in and not letting in. We need to put together some kind of list of folks that they can't bring in. Okay, so they're still they still want to control things, but they don't want to do the work associated with it.
Kind of like letting your kid live in the garage and saying, well, you're on your own. But then, since you're in the garage, you got to do this and you got to do that.
That's right.
It's like, it doesn't work.
So the preclusion list is a list of folks that are, and they actually use the term bad actors.
They do.
It's a list of folks that CMS considers to be bad actors, and as such, they are not eligible to be credentialed for Part C and D.
Right. So these are folks. Now, since everybody who's excluded can't be credentialed already,
Yep.
so it's a separate list from the exclusion.
It is. It
right?
is complete. And plus the exclusion list is public. Okay.
Right.
The preclusion list is like, double dark secret. Top secret. Only insurance companies and law enforcement have access to the preclusion list.
That's right. Which is totally crazy, if you ask me. But
yeah,
nobody asked me.
Because it's possible to be on the preclusion list and not to be excluded.
Right. Absolutely.
So it could be that someone's a bad actor and they come to you to get a job, and how would you even check?
Right. And the fact that the revocation, people who have been revoked, is a public list now.
Yes.
Made recently.
Yes.
And most of the people on the preclusion list are people who have been revoked or have been.
It's the big issue. Yes.
Have been denied access. So it's basically people that CMS has come in contact with, and they wouldn't allow them to provide services
for Medicare.
For Medicare.
So they took away their Medicare billing privileges.
Right.
Or they said, we're not going to let you have them to begin with.
Or right, they either denied them or they took them away.
Yep.
And they want the
Part C and D to kick them out too,
as well as
or to restrict them from billing. That's right.
That's
really the core of what the preclusion list is.
That's right.
Yep. Next slide. Okay, I think we kind of covered this. The bad actors. Yep. But it's really tough. All right, so there's really two broad categories of people on the preclusion list. And the first, as you said, is revocation based. There are, since 2003, it started, believe it or not, revocations were quite narrow 2 decades ago. I mean, the only way you could really be revoked, and they didn't call it revocation, is they could terminate your participation agreement if you didn't meet all the requirements or if you were excluded. That's in 2003. Then starting in 2003, they said, we need more power. And from 2003 to now, there are now 23 different bases that they can revoke your billing privileges.
Now I wonder if those are like all of those permissive exclusion bases, but they only really use a few of them.
I've done that analysis. About half of them, they're actually court cases, which means they had to go all the way through the administrative process, take it through the DAB, and all the way to federal court. Okay, so there are a number of them, but that come up, such as a pattern or practice of improper billing.
Right.
That's a big one these days, especially for hospice in California and Texas. But that's coming to a theater near you. Because that's what happens with all these programs. They test them out on people first and see how onerous they are, and then they expand it nationwide.
So it's very interesting that that's a major basis for being on the preclusion list, which you can't access, but you can access the revocation list. But that's a
different issue. So the first way is if you're revoked. That's the number one way to get on the preclusion list. Next category. Oh, and here's all the different, this is not all 23, but this is the most of the reasons why you can be revoked. And for home health and hospice, the big one, of course, is, not just improper billing, but failure to report a change in location or to keep regular business hours. The UPICs love to show up at noon, and if you're not there to answer that door, they will revoke you in a heartbeat.
They get lots of physicians who did locum tenens for a while before they got settled and then so they got credentialed under one place and then never changed it.
Yep.
When they moved, you've represented several like that,
Yes,
haven't you?
yes,
Which
yes.
is just awful.
It is. All right, next slide. Okay, and then category 2. You remember category 1 now, revocation-based. Category 2 is behavior-based or conduct-based. And essentially it's, if you've done something, CMS says, if you've done something that is so bad that if you were a member of Medicare, if you were a participating provider in Medicare, and we could have taken away your billing privileges, if you've done something that bad, even if you're not participating provider, then we can add you to the list because we think that you're a bad actor.
So I have racked my brains to try and figure out who fits in that category, because if they're already in the system, they're revoking them and they're using that.
Well, someone who is not a provider that has been convicted of healthcare fraud,
or maybe the people who have been denied, who have applied and been denied.
Yes.
It's the only thing I could really come up with that would fit that.
Yeah, I've never had a case where someone was kicked out for category 2. All the preclusion cases I've seen have been revocation based.
I've always figured, I haven't looked at it like you have, but I in the back of my mind I was thinking, other than a denial, if they've denied somebody in the first place, right? Or what if you have your credentials and then you come up for you have to renew them how often?
Yeah, every 3 years or so. Yeah.
So if you deny a renewal, is that considered a revocation, or is that
No, that's just a denial of a re-enrollment application.
So I bet those are, so they didn't.
Well, they would look at the reason for the denial, and then it's very possible that they would use it for here.
For that.
Yep.
So that would be like a revocation, and the same kind of idea, only they were just or a denial. They just.
That's right. But once again, no one on this phone call can even look at the preclusion list to see if somebody's on there.
Right.
But you should probably ask all your applicants, are you on it? Because, if they're honest, they'll tell you yes or no. And, it only really matters, I suppose, if you have patients that are under an Advantage plan. You're more than likely going to have a Medicaid managed care patient, because in most states these days, it can be up to 95% of the Medicaid patients are covered by managed care.
So
they send it to the last address. You guys are sometimes you update them, sometimes you don't. If you don't update the address, that's a problem.
And I think with a population that has, I know in nursing homes that I've read before, I know it's 100% churn within the course of the year.
Yep.
I suspect that in home health
and hospice
it's probably pretty close to that.
And for those of you who are doing personal care, oh my gosh, that's like twice as bad as home health and hospice when it comes to turnover.
And so the point of that is that these are folk who, if they're sending something to their last home address, and the OIG does the same thing, it really is very likely that people don't, not very likely, but it's not surprising that there's a large number of people who don't know that they're on the list.
And I've got a lot of clients who are very sophisticated. They're MDs and have been MDs for 20 and 30 years who don't know the difference between an exclusion and a preclusion.
Oh, absolutely. So, there you are. The length of...
the length of time that you're going to be on the preclusion list. Well, if it's based on an exclusion, because as you said, every exclusion is sent over so there can be a preclusion list as well. That is up when the exclusion is up.
When they let you back on.
That's right. But so just because you're eligible for you're no longer excluded. You're eligible to get your to reapply for Medicare. But as you said, oh my God, if it's based on a conviction, they're likely to hit you again because CMS can hit you with the revocation.
And we have seen that.
Yes, it's so sad and it's not fair, but it happens.
We have seen that someone who had their license, had no licensing issue, had been on the exclusion list, was off it, had been on the state exclusion and was off it. When they came back and CMS found that, oh, wait a minute, the conviction that was the basis of those things happened within the last 10 years, so we're gonna revoke it.
Yeah, it's bad, very bad. All right, so revocation action, this is especially harsh now. If it was before 2023, they could only revoke you for 1 to 3 years. Now it's 1 to 10 years, okay? And if it's a second revocation, they can do it for up to 20 years.
And what's the standard on those, Robert?
I hate to say this, but in almost all cases, CMS is going for 10 years every time, even though when they got this through the Federal Register, they said that they would reserve that for the most egregious cases.
They're all egregious, I guess.
They're all egregious.
Shameful.
And then you already talked about the Medicare or felony conviction. Okay. All right. Ultimately, only the plans have access to this, guys. But you still need to be asking the question, and you need to keep an eye out, because if you start getting claims denied because someone in your employ is on the preclusion list, you need to pick up on that immediately. Okay. Yeah. Next slide. All right. So what are the differences between the two? Well, one, of course, is the exclusion list you can see, the preclusion list you can't. Exclusion list is there's no collateral attack. On the preclusion list, there is an appeal process, but it's kind of squishy, and the standards are such that it's hard to get them overturned. The purpose of both of them, frankly, I think, is to keep bad actors. I mean, they don't call them bad actors on the exclusion side, right? But it's to keep bad actors away from the federal fisc and Medicare and Medicaid beneficiaries.
They're trying to protect patients and the program.
That's right.
As the goal.
Who has access? Everybody has access to the exclusion list. Only the plans and law enforcement has the preclusion list. The size. Okay. The exclusion list, 85,000. Preclusion list, it's really 85,000 plus 4,600. So it's about, because it includes everybody from exclusion too. Okay. A new database that's going to be that we're going to be adding pretty soon, though, of course, is the revocation database, which as of yesterday had 7,465 people on the revocation database. And I understand the exclusion screen is going to be screened for that too soon enough.
Should be. That's true.
Penalties. I'm glad we didn't list the penalties. The penalties are egregious under both categories. Okay. I've never seen anybody hit with CMPs for preclusion yet. It's still out there and still new enough that they haven't done it, but it happens all the time on the exclusion side. In your example, oh my God, $800,000 for a personal care aide? Outrageous. You have to screen, guys. You have to screen.
So this is a case, we're done, but this is an example of why you would screen all of the states and the LEIE. So this is a real case. It was 2019, right? A suspended nurse practitioner, legal prescriptions, 294 count indictment, and there we go. So now we go. The person was convicted. Go to the next slide. And here's what we see. So the state of Pennsylvania, they call theirs the preclusion list. They're the only ones other than
that's confusing.
It is confusing, but they're meta-checker. So they excluded they terminated this guy in actually before even the indictment came out. They were Johnny on the spot, right?
Yep.
Bad guy.
Yep.
January of 2019. Right? He made it to the OIG's list, and look at that. 2024, 5 years, 5.5 years it took to make it from the one to the other list, and as far as the last screen that we did, he's not on any of the state list. So This is why, now, obviously, this 294 account guy
Yep.
who gets convicted, who's chucked out of Pennsylvania, takes 5 years. Yeah, this is why you screen every month, and this is why you screen all the states. He's just not someone he's bad news for your practice. But theoretically, he could have been billing Medicare. He could have been providing Medicare services and Medicaid services in every other state between 2019 and August of 2024.
That's
So,
crazy.
That's right. And that's why you do it. Here's
Yeah.
the why. So,
Yeah.
and those are our pictures from, these were last week, right?
Yeah. Yeah. That's my hair looking gray. Yeah. That's embarrassing. We need to change those pictures. Okay.
Probably not. We don't want to change them.
Any questions? No questions. Guys, I know that these issues can be complicated, but please feel free to give me a call, or preferably Paul a call, because he knows this stuff better than I do. And we're happy to answer any questions that you've got. Thank you so much for your time.
Thank you so much to Representatives Robert and Paul for that information, and thank you to our attendees for joining us today. I'll be sending a copy of the PowerPoint slides tomorrow, and if you have any further questions, please reach out to them like you said. Have a great Tuesday, guys.
Thank you.